Never paid for 5 months. And when he caught COVID, he could not afford the services he was offering. Those are the true stories. The nurse from Isiolo, as the county was launching ICU beds, when the poor nurse got COVID, she had to die on the way to come look for ICU beds in Nairobi. Those are the true stories. So that sometimes when I hear people say that our systems were resilient enough, we didn't have a lot of deaths. One death that can be prevented is already big enough. There's an empty dinner chair that will never be. So that even when we have just a single death in a day in the data, that's a family grieving. And so long as it could be prevented, we have to call it out. And you guys know the number of healthcare workers we lost. And we also know those who still continue to suffer. I know of a nurse who went to ICU and all that, and though she made it through, she still has to walk around with an oxygen cylinder being dragged around. Her life changed forever. We all know families impoverished, sold land, sold property, healthcare workers to treat their loved ones. You know about the black tax, where when you are the most successful in the family, you have to cater for everybody's needs. All of you guys are still paying loans that they paid for their sick parents, all brothers and sisters, when they caught COVID. True or false? That's their reality. So as we sit here, and I remember when we were sitting planning for this conference, for me it was very clear in my mind that I never wanted this conference to be like any other, where we just speak the academics, drop the numbers, and then we move on. As healthcare workers, we are all seated here. We must get impatient with what we are being served. We are baking a bread. We are employers in a bakery. There's the owner of the bakery. We're telling them that the consumers are complaining that the bread is not good enough. And even as we bake this bread, we are struggling with the ventilation probably in this room. But the owner of the bakery keeps on telling you that no, continue baking. While for him, when his family wants to take breakfast, they import their bread elsewhere. The healthcare service we are offering Kenyans and the ones we are receiving is not up to date. So I'll make it quickly about COVID. So apart from the deaths, there were the illnesses I've talked about and the work overload. Before COVID, the numbers were really terrible. The nurse to patient ratio, the doctor to patient ratio, even the clinicians, it was terrible. We all agree. Then this pandemic comes where people have to be removed from the rota because they are sick without being replaced. Where we have to scale down some of the services we are offering because of COVID. And I remember as KMPDU, we used to have this weekly press conferences pressuring government to hire more. People are suffering, people are getting burnouts. To no avail. And in the long term, we ended up with healthcare workers who are just turning up for work. I remember when I lost my poor uncle, and they'd only do a ward round at over at 6 till tomorrow morning. So at around 8 p.m., the poor old man called me that his mask had fallen off and he couldn't pick it. Whether could get somebody to just go in and pick it. By the time they went at around 3 a.m., they suffered a cardiac arrest just because the mask fell off for oxygen and he couldn't get it. And you can't blame the healthcare workers because there are probably just 1 or 2 doctors and some few nurses. By the time they're done one round to the other end of the round, the night shift is over. And the healthcare workers witnessed all these preventable deaths. I remember when my old man was now in ICU and the doctors were like, nothing can be done because it's too late. And everybody who comes here, sadly, they die. No, we're doing the family conference. And the healthcare worker had to carry all that burden of seeing that we are losing a patient for something that could have been prevented. I'm sure that so many of them are still suffering from the emotional torture and trauma. And did anybody check on them? When I caught COVID in Kenyatta, I remember I was sick. I got my result. And I was just given my result and told to go home. Nobody told me that go there for counseling, do this. They called me like 3 days later to check on me. And I was like, if Kenyatta of all the places and I'm a deputy SG of KMPDU. Just, I'm not special, but at least they should pretend that, nobody has ever checked whether he recovered or whether he died. Yeah? But it was terrible, I tell you guys. And these stories are told by all healthcare workers across, not just us. Issues about PPEs. How many times did you make noise about PPEs? Yeah? All the time. No mask. No. Unapewa mask moja, you get in the morning till evening, just one mask. Seeing all those patients. I'm sure probably that the healthcare workers were even infected more patients. What about the lockdowns and the curfews? I remember the Muranga doctors being locked and tear gassed in Thika as they were moving from Thika to Muranga. I'm like, they had their work passes. They are going to work. And we told them as KMPDU, then stay home if they won't let you pass to go to Muranga to the hospitals. And you guys know so many others who are beaten up and all that. What about the salaries? We had a strike during the pandemic, I remember. And we struggled with, do we do a strike? How would we look calling for a strike in the middle of a pandemic? But when we saw what Mogusa had gone through, what that nurse had gone through, and we've been talking about it for weeks on end, we might have looked heartless. But when you have to work and you're not being paid for 3 months, the banks are closing on you, you cannot pay your rent, and somebody calls you you're a frontline soldier, frontline worker, frontline what? We know how frontline soldiers are treated in the West. We saw. So you cannot be frontline workers when you are there just being pushed around suffering. Unaambiwa tu your nation will clap for you and honor you. Have they honored us so far? They are here. Yeah. Flowers. Yeah. Ni flowers tunapewa. Yeah. So we have to agree that in this pandemic we got a raw deal. And what really breaks my heart is that at one point finally governors were like, we need to stock up the ICU beds, the oxygen spots and all that, concentrators and all that, and they were given money. Like, I'm sure that if each all of you were given a chance to tell us about those ICU beds, you can really tell a very terrible story, right? Because there's no ICU bed. And there's like an ICU bed. An ICU is a whole setup plus a human resource in it. Not just putting a bed that can move by a switch of a button and a monitor on the wall. And you're told that an ICU bed. They didn't exist. Yet money was spent. Because it is cheaper and it's more profitable tendering for brick and mortar than the key thing. Now, if you have a healthcare worker who is properly trained and the right numbers, they can always bag a patient. But that machine won't. My uncle died because nobody could pick up a mask and put it back on his face. And the oxygen was there. The masks were there, all those things. So it all boils down to the human resource, the numbers. I want to talk about the COVID-related deaths that happened in this country, and many a times we lose it. The chronic diseases, the cancer patients, whom we diagnosed at cancer stage 2A, the CA cervix, and they had to go disappear because the clinics were closed, the lockdowns, and when they came back, they were in stage 3 or 4. Do you ever remember about them? And how do you feel as a healthcare worker that you picked up the diagnosis so early? Something could have been done, but nothing was done. What about that diabetic patient who died because of hypoglycemia, because they could not come for their dosages to be reviewed? They are there, and we know them, and we must speak for them. I want to talk about the issue about the joblessness in this country. That as we complain about the numbers and the issues, we know we have a pool of healthcare workers who can be taken up and employed. True or false? But every time we say that we are being overworked, we want you to employ more. And we have brothers and sisters who are languishing, who don't know after internship where they'll go next. And nobody speaks their language. And luckily enough, with the globalization of COVID, I'm finishing. Of COVID, we know that probably the other countries do know how important as healthcare workers we are, right? And probably as unions and associations, we must cast our sights to other places. If I treat in Kenya or I treat in the UK, I'm still treating God's creations. True or false? I'd rather save a life in the Caribbean than idle as I roast maize in Kipingi market in my village. Finally, as I finish, one moment is that we have the elections coming up. We hope and dream that we are going to politicize healthcare. I like the fact that we are talking about the economy. Beautiful. Of course, COVID taught us that there's no economy without health. And so we must talk about healthcare. I'm hearing about Baba Care. I think Ruto is talking about NHIF. Beautiful UHC and all that. Let us bring the component of the human resource into the debate. And I hope that towards the elections, we can have our demands as unions put up in a document and make the politicians commit to it. Otherwise, next time, it won't be business as usual. Thank you, and for the memories of all those who died, may they rest in peace.
Thank you. We've had wonderful discussions, very incisive, precise, to the point. I just wish that a day will have 48 hours, or the sun will stand still. Maybe one day it will. What Dr. Miskellah said is the whole truth and nothing but the truth. I can lift up my hand and say it is the truth. I believe in it, hook, line, and sinker. And there is no need to argue around that. That will be akin to starting a long conversation discussing whether the Pope is Catholic. Now, at the end of this panel discussion, we are moving to the panel discussion, and it is my hope against hope that we don't just have a high blood pressure of words and anemia of deeds as we leave this place. Let's couple up this beautiful talk shop with the impactful action. And now allow me at this juncture to call an end to the discussion and see us to the next frontier. This is going to be very invigorating. As the panelists make their way back on stage, kindly, you'll allow me to introduce the moderator. He's well known to you, a seasoned journalist, a news hound, and agent provocateur, Mr. Debalania. Take the sound device and take it out from there. Asanteni sana for being keen on the previous.
Good afternoon. Good afternoon. Well, I can see we're really pinched for time. We were supposed to be now having our lunch, and the predicament of being the person who's standing, between this session and lunch, you have to really hurry up so that I don't keep you here for long. But nonetheless, the conversation continues apace, and this is where now we are engaging our panelists. I will actually go just through the questions very, very, very swiftly. And then afterwards, of course, we'll open the plenum where you can actually engage them, ask them questions, fire away also your commentary. And brevity will be of essence as well. Thank you so very much. By way of introduction, my name is Debalania. I'm a programs editor and broadcast journalist with KTN News. And I'm delighted to be your host and moderator, so to speak, for this particular session. But before we move on, kindly, because you've been seated for long, why don't we just stand up and we do a little bit of an exercise just to jumpstart, of course, our attention again. This is going to involve a lot of, attention, stretch a bit. But I want to remind you of the hashtag that we do have, that is the KWAC 2022. That is a hashtag. I can see no activity so far on Twitter, but I know you have your smartphones. How many of you do have your smartphones with you? Good. Just raise them up. I want you to do an activity before we settle down and discuss. I just want you to go to your camera and go to your next neighbor. Now social distancing is, as we've heard, the infections rate are going down the tubes. We're at 0.03. That will be going to 0 at the end of the day. I want us to just go around. You can take a selfie with your partner, the person who's just near you, and make sure you post that particular photo on that Twitter handle, right? Use the hashtag KWork2022. Hey, take selfies, take selfies, take selfies. Take selfies. Yeah, you need to immortalize this particular moment. Yes, to remember this convention is a big one. After going through a very torrid times with COVID-19, finally, we do have a breakthrough at the end of the day. But lessons have to be learnt. Good. I'll give you another few seconds to just do it. Our panelists as well, you can actually take, the two of you are from the panel here. Yeah. Fantastic. Okay, so don't sit down yet. You've done that. Thank you. Thank you. Okay, another activity, right? Just briefly. I know we can sanitize afterwards. I want you to just show me your finger. Where is your finger? Show me your finger. And it's a political season. I'm not really going to your party, and that particular symbol is for a party. But I want us just to do an activity, just jump starters, and then we settle down briefly. I want you to, where is it? Don't put it down. So I want you to trust me. You close your eyes. Close your eyes. I want you to go back to your geography and your campus. Close your eyes. You follow instructions. You normally tell our patients, hey, come on, raise your hands. We do raise our hands. Show me your tummy. We do that. Okay, close your eyes. Raise your finger way up. That is the index finger. Good. With your eyes closed. Show me where your true north is. Your true north. Where is your true north? Close your eyes. Don't open your eyes, please. Where is your... point where your true north is, please. Don't put your hand down. Point towards your true north. Where is your true north? Having closed your eyes, are you certain about it? Are you sure that is your true north? Close your eyes still. Let me consult my compass here from my phone. And don't change, don't look around, right? Mwakenya is not for now. I want to consult my compass. Then we see where our true north is. Don't get tired. And where is my compass here from my phone? Let me just try and get it so that now we can know where our true north is. Here's my compass. Don't put your hand down. Wait, where are the hands going? Up. Show me where it is. Show me where it is. All right. Without putting your hand down. Without putting your hand down. Open your eyes and look at your neighbor. Ask your neighbor, is that your true north? You are almost poking my eye. Are you sure that is your true north? Are you sure? Don't put your hand down yet. Are you sure? Okay. Msema kweli yuko hapa. This is my compass. And my true north will be looking at my compass that direction. If you got to clap for yourself. Fantastic. Last bit one. With that particular finger. With that particular finger. Right? I want you to house your neighbor's index finger like this. Where's your index finger? Just like that. Yeah? Like a zigzag. So house it. House it. House it. Yes. Yes. Just like that. House it. House it. Yeah? Everyone. So we have a sort of a zigzag, right? On my count, I want you to grab that finger. Okay? Follow instruction. On my count, I want you to do what? Okay. Are you ready? Let's do a dummy run. 1, 2, 3. Grab it. Okay, that's a dummy run. Let's go now to the exercise itself. Are you ready? Let's do it. Of course, make sure you sanitize after this. Are you ready? Okay. 1, 2, 3. Grab it. One final one. I'll give you another chance to redeem yourself. Let me just give you the final one. Okay, are you ready? Okay. 1, 2. Hey, follow instructions. Please follow instructions. Okay, let's go. 1, 2, 3. Grab it. Fantastic. Clap for yourselves and have a seat. Thank you so very much. Let's just go straight to the panel. And we know the subject matter right now is the COVID situation, lessons learned, and post-COVID-19 recovery and resilience strategies for health resource, human resource for health. That is the subject matter. And we have our panelists here right now. I'll just give him a handy opportunity. I hope we do have our mics ready as well. We have another one. Each of us we have? Good. Let me just give you this as well. Thank you so very much. Just to remind us where we're coming from. You know, when we had DMS here, Dr. Andrew Muller talking about being soldiers. And even right now, we are in torrid times of the Ukraine war. We're coming and smarting still from COVID-19 effects of it. We've heard how people have gone through torturous moments with the long COVID itself. Right? A word that was coined by Elisa, an archaeologist, Peguero, who said the long COVID effects are still with us. Even after you are in the ICU, you're still dragging around with an oxygen, bottle, because these are the effects of COVID-19. We've heard of how also the B cells in the immune system, they still remember the virus, that people are going back to the hospitals with a cough. And it's not really from a flu, but this is a memory from the B cells in the immune system. It's not going away. People have migraine headaches. They'll tell you, I got this thing last year, but I'm not okay completely. We're talking about the post-exertion malaise. You know, you're going to the gym at the end of the day. You want to exercise, run on the treadmill, but you feel exhausted. There's this chronic fatigue that is just with you. The long COVID effects. The long COVID effects are with us. But what lessons are we learning even as we are coming from this? We are soldiers. You are soldiers. We in the media, we are celebrating the health workers. And we said, oh, we can see how they're giving up their lives. They are going to the danger zone. Why can't we hold some moment worldwide and clap for our soldiers? Clap for our health workers. We are the people you are the people who are in the front lines. We are celebrating you. But today it's appalling to hear that still all that you'd put front to be given, the PPEs, were not given at the end of the day. We had the COVID billionaires coming around. Today you saw the headlines as well on the Business Daily. How a tidy sum of money are still, in KEMSA's stores as dead stocks. Yet these were the PPEs people needed. The masks. You couldn't even get a mask. This is where we are. And he says we are soldiers. And what do soldiers do sometimes? Right now we have all these military doctrines and military strategies that are coming to the fore. And they're saying, in the military, there is the 3R. Sometimes also in the war, you need to retreat. You need to recoup. And you need to relaunch. And this is where you are today. In this convention, you're retreating from the battle. Being battered by the COVID-19. The year 2020 will be, as Queen Elizabeth once said in 1992, the annus horribilis. When her family was mired in marriage scandals, 3 of her children, including Diana and Prince Charles, in that same very year, the palace was razed down in fire. It took $67.7 million to renovate that particular palace and to restore it within 10 years. This was my annus horribilis, the year of uncertainty and the year of turmoil. And 2020 was our year of annus horribilis. So ladies and gentlemen, having that set the tone for that conversation, we know where we're coming from. And it's very pivotal that now we are retreating, we are recouping. But when are we relaunching? You're still a soldier. You need to be very strategic. And she asked the moderator here a very pertinent question. Are we pandemic ready? Are we ready for the next pandemic? That is a question that should be hanging on the rafters of our mind this very afternoon. And there is this question that is coming from the statistics. I just want to whip it up quickly for you. Then we settle down for a discussion. And then you can go for your lunch. And they were asking a very pertinent question here. Where is it? They're saying that the next time could be worse. The National Academy of Medicine predicted in November 2021 that flu epidemics akin to one in 1918 and 1919 could prove more catastrophic than COVID-19. The preconditions for such a disaster are in place right now. A warming planet, mega cities, mass migration, intercontinental travel, and a habitat loss. These are some and among the reasons that infectious diseases like intensifying typhoons and hurricanes have become part of our lives. So let's settle down and discuss with the panelists right now. Allow me just to also take my place and engage them on this. So I know we had Dr. Andrew Omulwa with us here, but I can see he's not. Yeah. Okay, thank you very much. Dr. Davji Bimji, I know you're representing him. You say he's in a TV talk show. Or on NTV. I thought he's on KTN. Which NTV? Which station is that? I'm just saying this with my tongue family in cheek, don't worry. Also, we do have with us Wilfred Kimani. Welcome back from Dosh. And Michael Nyongesa is being presented by Teresa. Teresa, you'll just give us your full names as well. And I give you just 1 second to make introductory remarks. Each of you to just make introductory remarks we've heard from you, so you don't need to belabor the point. Briefly, let's start with you.
Thank you very much. My name is Teresa Ireri. I'm National Secretary to Kenya Progressive Nurses Association, sitting in for my chair.
Right, thank you. Daktari.
Good afternoon. I'm Wilfred Kimani, representing the Directorate of Occupational Safety and Health Services.
Thank you. Daktari again.
Good afternoon. My name is Dr. Simon Kibias. I'm here representing Dr. Andrew Mulwa, but I work with the Ministry of Health at the national government. I head the Directorate of Health Standards Quality Assurance. I'm a public health specialist, so I'm happy to be here today. Thank you.
Thank you. And lastly,
Once again, I'm Dr. Miskellah, the Deputy SG for KMPDU.
thank you. Okay, let's just get down to brass tacks and we get to discuss a raft of issues. And we know the topic at hand is the COVID situation. The lessons, excuse me, we've learned on post-COVID recovery and resilience strategies. Listening to, the presentations here pretty much has been covered. It is just to tease at what they've been telling us and drill deeper with it to see what is a way forward at the end of the day. So my first question will be, the Global Health Security Index for 2021 rated the world's 195 countries as dangerously unprepared to deal with future epidemic and pandemic threats. And this is a question that I want to pose to you, Simon, that now you're representing Dr. Andrew, from the ministerial perspective, listening and hearing this particular ratings that we're getting from the Global Health Security Index, dangerously unprepared, and now that we're smarting from COVID-19, which is going down the tubes as well, are we relaxing, or as an army, we are recouping for the next war to be relaunched?
Thank you so much for that question. First of all, I would like to thank all of us, all the frontline health workers, and all the support staff that have participated in the pandemic control in our country. Thank you so much for the good job you're doing. As concerns preparedness, I think possibly we are still in the responding, between responding and recovering phase, so we are not yet out of the woods yet on this COVID-19 pandemic. But as we are hearing from the speakers and all the experts globally, we are putting in place some measures to build back better. And that is very much in keeping with the disaster risk management cycle, whereby once you are hit by a disaster, say, for example, this pandemic, then we need to look at the gaps that we have, and it all ranges from when you have to look at across all the pillars of the health system. Really, you have to identify all the gaps, and I think for us, speaking for the country, it gave us an opportunity to look into when we did the assessment, for example, the assessment of the preparedness of the counties to mitigate the pandemic, this COVID-19 pandemic. We went out there with a joint, a health inspection checklist that brought out quite very clear gaps that were there, all the way from human resource gaps, infrastructure, equipment, medicines, supplies, and everything else that we saw. And I believe all of us here who are working across the country, within the county, we owned up to those gaps, and we started working on them. The counties promised to put health workers in place, some on contract, and others maybe permanent. And you saw them try to run around to have the ICUs. You remember that, I believe. ICUs have equipment in place, oxygen concentrators, oxygen plants, and so on and so on and so on. So all this, we could put it together to mean we are, as a government or health sector, we are trying to build back better, put in place immediate action points, actions, and long-term investment in the health sector so as to build back better. Build back better means we should be, when the next pandemic hits, it should not find us in the same preparedness status. So we are not yet in the preparedness phase, I could say that, because we have not yet put all the measures in place to ensure that we are prepared for the next pandemic. But the processes have begun, and is evident all round. So
will you kindly tell me just in a nutshell, what are the processes?
What are the processes?
Yes. If you just
the process, for example,
now.
Yeah, like for prevention, I think we have made a milestone. For example, in the vaccine prevention measure, like the Biofax facility, putting Kenya in the position of producing vaccines is a good one to start with. I mean, tomorrow, next time we face with another pandemic of infectious disease nature, viral, whatever, we have the mRNA technology now patent. Hopefully by then we will have developed the capacity to develop vaccine on short notice. So that alone tells you that we will not have to be waiting for months and months to get a vaccine in place.
Thank you.
And then health workers recruitment. It found us while still implementing the UHC strategy, where we clearly pointed out the gap of UHC. Top number one is a human resource. So we are not yet at 23 per 10,000 population ratio of health care worker to population ratio.
Thank you.
Yeah, we are still around 13. So we're still very far. That's one I cannot tell you we are there yet.
All right.
But counties are promised through and in the participatory agreement to recruit progressively health workers. And I think all of us have spoken is that we are not yet there. We don't have enough health workers yet.
Thank you.
So we have to address all the building blocks.
So allow me to butt in and say thank you. Yes, but still the question of vaccine hesitancy is lingering with us, even as we will be having, Moderna setting up base here in the country. You, as a ministry, you've dismally failed to convince Kenyans to get jabbed, double jabbed. Because in the beginning, of course, people had bugbears and fears about these vaccines. There was really a lack of civil education that came from the minister. But I want you just to marinate on that particular question as I go now to KPMDU Deputy Chair to just tell us, you've heard, and I'm really touched, that some of the stories that you've told us this afternoon, they need a follow-up. When we talk about vicarious trauma that health workers are going through, and I've just told you the effects of the long COVID. So you are affected by COVID as a health worker. You've been impaired in some way or another. Let's say, for instance, as we know, that part of COVID-19 can adversely affect your brain. We've had people who are coming out of COVID-19, they've lost sense of smell. The olfactory, a part of that brain is not really working. It has been adversely affected by COVID-19. They cannot recover. You've talked about a health worker who right now, she's walking around with an oxygen bottle. We have director here from DOSH, Occupational Safety and Health Services in the country. This requires compensation because they were at work and they were affected by this. This is affecting their family, right? If this is a mother, she cannot now be fully in a full faculty to really also offer her services still back at work and even be a mom at home at the end of the day. In terms of compensation, and the ministry is here then, how do you advocate for this lost sense of smell? Oxygen bottle walking around, and many others as well. People who are coughing continuously, they cannot really work when people will have bugbears and fears about COVID being spread around. Now we're losing our masks at the end of the day. We know in China, also some parts of China, they're locking down. We know in USA right now, there is another variant where they're calling it, they're calling it a Delta Omicron. A coinage, but it has not been verified by the World Health Organization at the end of the day. Compensation.
Thank you very much. Yeah, one of the key messages I think I've taken from this session was the issue about the safety at work from Dr. because the truth of the matter is that the awareness is quite low. Even the 40 cases and claims that you have, that's way low. Yeah. And as a union, as KMPDU, I remember when we had our strike, one of the issues that we raised was the WIBA compensation. Just apart from the NHIF cover, it was the WIBA compensation for the treatment of the healthcare workers. So I'm glad that you have raised it, and I hope that our sister unions and associations, we now know that they are directorate, the ministry, where we can take those issues that have come up. And that for me is a really big plus, because I can assure you that come Monday, we might be knocking on your doors with a lot of claims.
All right. And I think this is...
Could I add to what you said?
Please.
Thank you, Dibal. Thank you, Dr. From the occupational safety and health perspective, just like curative medicine, prevention is always better than cure. And like in this case, in COVID-19 and many other occupational diseases, there is actually no cure. You can only treat or manage the condition. So specifically for COVID-19 was recognized as an occupational or workplace disease by both the International Labour Organization and the World Health Organization for frontline workers. Because remember, it can also be community acquired. But specifically for frontline workers, it was recognized as a occupational or workplace disease, which by extension means it is compensatable. So we are open, Daktari, so you can lodge the claims. As I said, we've only received 40, which we know is grossly understated. and only from 2 counties, Garissa and Wajir, surprisingly. Thank you.
So there is compensation.
Yes, it is.
Fantastic. And it's good to know that at least there is compensation. I don't know. I'm wondering what, Teresa, you will say when you're representing also the nurses as well at the end of the day. You have cases, I know, that story that we've had from Deputy Chair here. Also, you do have stories that maybe you can give us some of examples that you can relay that also to Dr. Kimani.
Yeah, thank you very much. I agree. You know, nurses and nursing profession is the largest workforce in health. And so when we are being affected by COVID, it affects largely a greater part of our professionals. So I don't know why only 2 counties have reported. Probably what I'd say, during the 2020, we really made out statements and calls for compensation together with the unions as professional associations. And we didn't know, or probably there wasn't mechanisms that were existing that were clear to everyone on how to handle this. I think we can do better in terms of the department or directorate to capacity build people. If we are the frontline workers, we are not aware of how to fill the forms, we don't know where they are available, then that's a big gap. Because we need the compensation, yes, for each and everyone who gets workplace infections, not only for COVID, but for others. Yeah, so the call is upon. I was happy to hear that they're having trainings ongoing in the counties. I would like to have them map out so that we all know, and especially as leaders, when DOSH is coming to us to mobilize and sensitize our members on the same.
Okay, so I was just wondering, you don't work in tandem also with KMPDU in terms of having empirical data to collect it? Because they are very handy right now when it comes to compensation, but you don't have any empirical evidence or data you've collected that they can work with at the end of the day. So collectively, moving the way forward, are you, but a Deputy Chair, you can tell us, I think now you can join forces together and say, yes, we need, because only 2 counties have been, lodging for this compensation, which is really appalling. And hearing the stories that you're telling us, they were just stories at the end of the day. You're not putting tails on those particular stories.
I fully agree with you that moving forward as the unions and associations in healthcare, I think the key thing we must do is hold the directorate accountable, in that we can organize training starting by our shop stewards and the officials to know that if there's a case that can be reported, not just for COVID, the other cases and other injuries that have occurred at the workplace, that we can then know who to call or who to reach out for. And as I said, that is a learning point, and that's why I'm really glad that we had that discussion.
Right, and Dr. Kimani, for the point of view of complementarity, if you know you have such a budget within your ministry at the end of the day, and you can see how also the health workers were really suffering, and we're talking about even the vicarious trauma, we've heard about the mental health at the end of the day. What is the scope of this compensation? Maybe you can just elaborate and tell us what is the scope of this compensation we're talking about, because now we have different facets. We have people who mentally they're affected. We have people who they've lost some senses of their faculty. It cannot really work as it was before, and that is adversely also affecting, their livelihoods at the end of the day. Could you kindly just give us a scope of what compensation we're talking about?
Okay, thank you, Dibal. Just a clarification. We don't have the budget to pay the compensation. We do the administration.
The administration.
The budget is with the National Treasury. And they are also working through the NEHIF.
Okay.
So we do the administrative work, we process the claim, and then we forward to the National Treasury for the payment pattern. Then what is the scope
But you could be having a sorting idea what the Treasury also is holding in terms of budget, so that we know what figure we're working with and what is the process if we are to lodge this particular claim.
Okay.
So that we're not really groping blindly.
Okay, for the last financial year, if I remember the figures correctly, the National Treasury set aside 800 million Kenya shilling for compensation for workers, civil servants. This includes even the National Police Service. So it had set aside a budget of 800 million. currently, they are projecting to set aside 1.2 billion in the next budget. Now, the scope.
Yes.
Anyone who develops an occupational disease, or you have an occupational workplace accident which leads to permanent loss of function or permanent loss of a body part. Maybe you're a machine operator and it amputates your hand. You qualify to receive compensation. Now, this compensation is guided by the document we call the Work Injury Benefit Act of 2007. At the back of it, it has some 8 schedules. The first and the second schedule guide us as to how to assess you for this compensation. So anyone who develops an occupational disease, as guided by the International Labour Organization, so we use the International Labour Organization standards, anyone who develops any of the occupational diseases recognized by the ILO, which leads to permanent loss of function or permanent loss of body part, qualifies to receive this compensation. We do not compensate for pain, loss of blood, or injury. You can be injured, and after you complete your treatment, you have recovered fully. So if you recover fully after treatment, you don't qualify to receive the current compensation as outlined by the Work Injury Benefit Act. But we are working, and this has been feedback from even our customers, mainly the private sector, because the public sector has been paying, but private sector, they've been having very many issues. So through feedback from them, we are trying to move to the social health insurance compensation mechanism. Why? Because the current mechanism is very acrimonious. It's about, as you called it, vicarious liability. Who is at fault? So if you're at fault, you pay. But in some of these things, no one is at fault, but someone was injured. So who will pay if there's no one found liable? So the international best practice has moved to a social health insurance scheme where everyone pays to a common pool, and anyone who is injured is paid from that pool. So we are working towards that, but that is still a work in progress. The current system is about who is at fault, so who should pay. The law also requires all employers to have an insurance cover in the eventuality that any of their workers is injured at work or develops an occupational disease, so that the insurance cover is able to cover for that compensation. But for the public sector, the insurance cover is the budgetary allocation that the National Treasury sets aside. So I hope I've
been fantastic.
Thank you.
And I think it's quite clear for everyone as well. The wider scope on it, now you can take advantage. You're all the wiser as far as that is concerned. Let's just come back to the ministry and the government. In the beginning, of course, we understandably, we didn't know, we didn't have any sorting idea what COVID-19 is all about. And we had protocols from the ministry that we had to adhere to strictly to try and contain the situation, as it were. But from your own perspective, when the CS was coming to, announce that now we can lose the masks and go easy on the protocols at the end of the day, I expected also the CS to try and pacify the public on how the government, not only here in Kenya, but globally, how we treated the pandemic in the beginning. You can remember those scary scenes of, the gentlemen in the white hazards who are burying our family members. We could not, attend the burial because of a strict measure. But comparing to the, of course, ensuing years, like last year, this year, that never, happened again. But the families that were affected, because we were treating them like, it's a nuclear disaster, so to speak. And we understand during that time, everyone was none the wiser on how to treat COVID. But the simple act that could come from government and from the ministry was maybe even to apologize and say, you know, we were sorry. This is how it was by then, but it was not truly our intention. I don't know. From your perspective, do you think that will be the wisest of fashion to maybe treat it, even with the losing of these protocols? Here's your mic. It's just right ahead under your nose. Okay.
Thank you for your question. I really don't know how to respond to that, but I think communication, messaging keep changing, and situations change from unknown to the known. From the time when we didn't know,
yes,
not even most of us experts didn't have adequate information, then it was the issue of quarantine, and most of us participated in that, and we wanted to ward it off by all means.
It's true.
But because of weaknesses that exist, somehow it came through. So the story changed from prevention, quarantining to, that's the first principle to do when there is a threat, an hazard of infectious nature. That is the tradition what we do. We have to quarantine until investigations are done, until we identify the agent, and then know what to do with it. We have to keep people within the law as the law provides, within a certain specified time in a secluded area. And then we have to balance out between scaring the people into confusion, pandemonium, and then worsen the situation, or also but provide information to the degree of danger that hazard poses. But if once that is taken, then other measures are now put in place. But for about vaccine hesitation that you mentioned,
yes, please,
right now, I think it's good to know that we've already given out of about 17 million doses out. 7.5 are fully immunized so far, and 7.7 I think have gotten the first dose. That alone is good enough. It's good, but we are not yet at the target. We still aspire to get to 70% for us to get what we all of us know, the herd immunity. So we still have to continuously sensitize our people, especially the community level. The government began an aggressive program to mobilize the communities through focus group discussions, dialogues, to find out, to demystify, to find out the myths and other beliefs about the vaccine. And it was very interesting. We went around, I was in Elgeyo Marakwet County, and in some place they still believe that this vaccine interferes with the reproductive system, which we have to take time to demystify that.
Interferes with what?
The reproduction.
Reproduction, okay.
Yes, among other beliefs and myths. So we still have to work very hard to convince the communities to come out for the vaccine yet, because the frontline workers, the teachers, health workers, the uptake has been good, but for the larger communities, there's still a big number to cover. Yes.
All right, we've admitted, and I think this will be just the last round of questions to all of you. Just also, you wanted to say something briefly? Yes.
Just wanted to add something to what Dr. said. That also I think that it's time that the bureaucrats listened more to the healthcare workers, because when COVID came and the healthcare workers tried to explain to them, to tell them what was happening, but they chose to use the police and criminalize a public health concern instead of letting the public health officers, people who are trained to tell people why it's important to mask. Even the current vaccination, I still believe that it could have been done much better if it was cascaded down to the communities through healthcare workers. The public tend to not trust politicians or the bureaucrats, but they tend to trust the healthcare worker. So maybe moving forward, let public health concerns be handled by the public health and health care workers, not the other way around. Thank you.
Right. And I hope also, Teresa, you can help me on this when you're talking about nurses, and generally just health workers. Where it comes to, we've heard about this psychosocial support at the end of the day. We have Dr. Kimani here, and I'm wondering, I'm a great loss to understand then, what are the metrics you'll use to compensate for instance, the mental, not really disorder, but just the mental health, people who are affected depression, people who cannot really function as they did before. Because as I've said, you know, it is you who are seeing these patients every day, and you automatically, vicariously, you get to, or subconsciously, also register all this trauma at the end of the day, and beknownst to you, also you get depressed. But how is the compensation? I wanted to just get a nexus of, how then, what metrics do they use? But Teresa, I've asked you a question for, I think it will have been you asking.
It's okay.
You just give the perspective, then we hear from Dr. Kimani.
Yeah, very pertinent concern. I think we are sitting here talking about when the next pandemic happens. And I'd like to say from a psychological support point of view, the next pandemic is going to be a psychosocial one. Because of all these things that have not been dealt with, rightly say, these families that lost their loved ones, that no one has gone back to ask how they're holding up. People who did not say goodbyes to their loved ones, we didn't bury. We are Africans, and we know we must go to the burial site, put the coffin, and turushe mchanga. So there's all this that is happening, and for healthcare workers, the psychosocial aspect is that it is a continuous exposure to trauma. And rightly saying, we need to identify and call out what compensation needs to be given for this trauma that is that comes from our day-to-day work. Because it is not only from COVID, but even for lack of resources at the workplace.
Yes, it's true.
If I have a patient like Dr. was saying, we don't have equipment that I know I can treat this patient, I can make their life better and their quality of life, but I'm not able to do because my work environment does not support. That's already traumatic enough. So yes, it's right. It's a right conversation to have at this time. Maybe we need to understand how, from DOSH, we are supposed to do this compensation.
Yeah, over to you, Kimani, because it's not even just with the health workers. Even we in the media, sometimes we get this trauma. We read bad news every day. And I remember, just briefly, we read bad news every day. I remember during the terrorism attack that we had a few years back, after reporting on the terror that was happening at Westgate, we were brought on, support, somebody to talk to us and encourage us and hear about our issue. And one of my colleagues, she started crying. She just started crying at the end of the day, and she was now narrating all these things that have been bottled up in her regarding that particular day, because she was on duty when this particular news broke, and she was breaking the news. And at some point, they made a phone call to, the people who were at, by then, Nakumat. And she got all these castigations from social media. Why are you engaging, people who are in, of course, that particular zone where the terrorists are? You're exposing them. This is so irresponsible of you, the media house. And she really cried because she carried it at the end of the day for quite a long time, that she felt like maybe also she was exacerbating the situation at the end of the day. Myself, I think I had an interview with one person who was in IBC that particular morning. In the evening, he went missing. And I was pushing him to come for that interview, changing dates and telling him, no, you have to. I said, no, Duani, no, you have to. So for me, even after that 2 weeks, I felt like, hey, maybe I took part also in exposing this guy. At the end of the day, he disappeared, he was murdered. So these are traumas that we carry with us, but we don't get any support. And I can just attest to the fact that you face all these cases every day. We are human at the end of the day. We are not really made to see blood every day. As a matter of fact, we can say, oh yes, this is your work, but naturally, you're not bent to do that. But where is the compensation?
Okay, thank you very much, Dibal. Now, mental health is part of safety, occupational safety and health. If I'm just to try and summarize, in occupational safety and health, we have what are called workplace hazards, which fall into 6 main groups if we are to classify them. Biological hazards, which COVID-19 is the key one currently. Then we have physical hazards. Is the workplace too hot, too cold? Is the ventilation too bad? Are you Ergonomic hazards, the surgeons stand for long hours, which can also cause problems. Then we have chemical hazards, all the disinfectants that are used to clean and disinfect the workplace, the medicines that we use to treat or to prevent diseases, all those are chemical hazards. Then we have a group we call the psychosocial hazards. These are to do with what you're describing. You're relating with someone who is unwell, they die. Or like in your case, you're pushing this gentleman for an interview and then he was murdered. So mental health falls under that psychosocial hazard. Now, for us at the directorate, anyone, we require workplaces to have the safety and health committees, and these are some of the things they do. They carry out regular workplace inspections. They should be able to identify the presence of these hazards in the workplace. Then the law also requires organizations to carry out what we call risk assessments. And the risk assessments should identify the hazards that workers are being exposed to, and then they quantify the risk in form of, is it a high risk, medium, or low risk? And by quantifying, we mean what is the probability or the likelihood of harm actually occurring? A worker developing an occupational disease, someone dying. So the risk assessments, the safety and health committee workplace inspections, then once a year you do like an external audit. It's called an occupational safety and health audit, which is done by a professional we call a safety and health advisor. This is someone outside of the organization, so it's like an external audit. So all these inspections and audits and risk assessments should be able to pick the likelihood of mental health challenges. And once they're picked up, of course, people should go for treatment, but we know some of these mental health challenges, there is no cure per se, you only manage. So in such an event, the person is referred. We carry out an disability assessment clinic at the directorate, normally on Mondays and Thursdays every week, and the catchment is national. So when they come for this disability assessment clinic, then we'll be able, for example, in the event of mental health, we send them to a psychiatrist and psychologist for a mental status examination. Then that will guide us as to the level of permanent disability or inability, so that they qualify for compensation.
Thank you.
Now, the technical way of that compensation is you look at the percentage of permanent disability assigned after an assessment or evaluation of the injured worker or the worker who's having an occupational disease, and then you multiply that by their monthly salary, including any regular allowances they receive, and you multiply that by 96 months or 8 years. That is for permanent disability. And then there's something we call temporary disability. For some people, let's say they are casuals or contract workers, when they've been injured or they have an occupational disease, during the time they are receiving treatment, they are not receiving an income. So for them, we also factor in that period when you're receiving treatment, and as a result, you are not receiving your income. So for those people, there is also the temporary disability payments, which is basically the number of days you are on sick off. The average month is 26 working days multiplied by your monthly salary, including the allowances. So for some people, there is the permanent disability compensation plus temporary disability if you are not receiving an income during the time you are receiving treatment from your disease or disability. So that's how we do it technically.
Very important. Lastly, let me just come to Bwana Simon as well. Looking at the ministry, when you had COVID, and we know right now we're battling to look for a cure, we thank God now this is tapering off. We don't know. With COVID, you never know. It can go down again. You see, as I've mentioned, in the US, they have the Delta Omicron, which is a new variant, though it's not really that aggressive at the end of the day, but still, we're always waiting for the other shoe to drop. But one of the ticklish issue that also came to the fore was the fact that the alternative medicine, the herbals that we saw people coming up with, and the ministry was not really embracing. Yet we know they were working wonders in other countries. I'm aware also of very prominent professors who've come up with a herbal sort of concoction, and it was very furtively also blessed by the ministry, right? Because they registered that, and people have been taking that. We have even governors who were dying, of COVID in the ICU. They took some of this concoction, and they got well. But this never came to the fore because you wanted to just make sure people are vaccinated, but there is a cure that was somewhere. Where are we streamlining this alternative medicine, even with COVID, moving forward in terms of preparedness? Where will alternative medicine also be?
Thank you for that question. Participants, I think it's known to most of us that we have a bill that is in progress on traditional and alternative medicine, and that will take care of that. The Health Act recognizes the role that the alternative medicine can play. So going forward, I think
but Dr. Ari, if we have an emergency, do we have to wait a bill to go through the process of a house? All right, and people are dying at the end of the day because there's a bill in the house. We have to go through the process.
Your question is valid, but we have to strike a balance between ethics and the standards that are in place. Remember, we moved quickly to bring all the experts together to come up with the first management guideline that took care of the case management. Yeah, we had a case management committee composed of experts, and we respected what they came up with as the most viable option, because you agree with me that we do not also want, in a disaster management principles, for example, for us to understand, we get all manner of donations. We have so many options on the table, but if you're not careful, you can jump from one problem to another, because you cannot take in everything that comes in, because you quickly can tip over to managing other extremes because of probably antidotes that have not been subjected to some reasonable trials, for example. I hope that you agree with me that that can happen.
I do agree with
there was a bit of caution to it, but we didn't say it was not playing a role to it. Some were left for studies that had been approved. There are already studies going on in many areas. Others were debunked. Others continue to receive peer reviews and so on. And it will be made available once and we have an organ, the World Health Organization, that can actually provide the list of the certified concoction that can be used. But allow me to speak to disaster management itself. Having worked there before, I think we need to prepare to revisit how we can prepare the system to face any form of hazard. That is chemicals, biological, radiological, nuclear, or explosions. And Osh has already mentioned it. We don't want to come out of a biological agent that has given us this pandemic into possibly maybe a radiological or a chemical situation. You know what's happened globally. You can't tell what can happen, and then we are not prepared. So we need to revisit the whole hazard plan for our country, identify all the top 5 hazards, and then look at what goes into preparing for those. We already knew this, that our top 5 hazards, for example, the first one was biological or viral nature, because we already are faced with Ebola. We usually get a threat from Marburg across. And I think we were caught flat-foot, but we were aware of the hazards that we faced. But we needed to cascade the whole hazard plan down to the community, because the first line of defense is awareness. Once the community is aware of an hazard, then they can take any possible measures to prepare or prevent themselves from that hazard. So we need to go back and look at the whole hazard plan for the country.
Thank you.
Prepare, put a fit of bare minimum measures to ensure that if it happens to be chemical, radiological, nuclear, fallout, whatever, we should be
at a certain level of preparedness.
Right.
But otherwise, we will have again a situation whereby we are not prepared.
Thank you.
Thank you.
Right, thank you. I think those are the questions. But I want to come to the plenum right now, and we take a few questions. If I have a roving mic, someone can help me with that, so that we move on swiftly. We get at most 4 questions. And kindly, brevity is of essence. Be clear. Be very, very short, so that we can go for our lunch as well and continue pace with the program next in the afternoon, because as you can see, we are far much behind in terms of time. Okay, I can see a gentleman behind there. Please, you'll stand up and just give us your name and one question, please, and you can pick up one of the panelists, or maybe that you want to answer that particular question. Right, so hands please, hands, so that we can make it easier. Who is the next? And also, gender balance is very key. We've heard about the inequity. We didn't even talk about the vaccine inequity. There are a lot of things, and maybe we'll come from the plenum.
Thank you. Thank you, everyone. Thank you, Dibal. My name is Chris Onditi from Migori County. I'm really concerned about the occupational health safety and the compensation bit of it. We have a number of 40 being floated as claims. I would want to hear if there is any that has been compensated. And 2, we are aware of some of the health workers who died during this time. Are they compensated yet, or it's still the long process? Ultimately, my question is this a white elephant or it is real? Thank you.
White elephant or is it real? Good. If we have another question related to that, kindly just ask, so that we can just answer it in one fell swoop. I can see there is a lady over there. Oh, okay. There's a gentleman with the mic already.
Okay. I'm Victor Bwanjete from Kisii County. It happened that the conference we have learned about this OSHA and OSH. So thank you for that. My question goes like this. Some people, some of my officers were in Kisii County during the COVID-19 were dismissed. And also, it happened that during that time, we were complaining about the workplace, the environment workplace. At least right now, like 50 nurses have not returned to work with the county government. That's another thing. Does the occupational health and safety care for the people who were dismissed, their mental states up to now? Most of them, I'm told one of them is a watchman right now at certain road in Kisii. So what I'm asking, that mzee who is supposed to retire this year, is called Oigo. This thing care for him.
Thank you. Thank you, Victor. Right, there was a lady there. 2 of them, in fact. We'll come to you. So, Dr. Kimani, hope you're taking mental note of that. We had, the death question, the compensation, Victor as well, dismissal. Where do you really come in terms of compensation? Of course, the stress, the mental health that goes with it in terms of depression. Good.
Thank you very much. My name is Caro Adwera. I'm the National Treasurer, Kenya Progressive Nurses Association. My question is on OSHA again. I wanted to ask what is needed in terms of compensation. Does it require if somebody was admitted, not admitted, whether it was vaccinated or not, and how much is it? And what is expected apart from the form, after filling the form, what else is expected of somebody who wants to claim? Thank you.
Well, thank you, Carol. Right, we had a lady ahead of you as well.
Okay, thank you very much. My name is Anne Mlengeka from Kakamega County. My question is to OSHA. Okay, concerning the risk that is involved in our health facilities. For example, a person contacts TB while at a place of work, and the person gets treated and they get well without having those disabilities they were talking about. Is the person eligible for compensation? Apart from TB, we have like COVID-19, we have those who didn't have like totally disabilities. Will they be compensated for the same?
Right. The many of them, I think once they reach 5, or maybe with the indulgence, if you're not in a tearing rush to actually go for lunch, we can take more. All right, are you willing? Let's hear.
Yes, good afternoon. I'm Janga Catherine, the Vice Chairman of the Morticians and Allied Profession Association of Kenya. I'm a mortician. And when this one goes to my fellow colleague Teresa, when you're reconsidering the nurses and the doctors and the rest, morticians tend to be forgotten. And especially that time of COVID. And we were so much exposed in a point that we were even mentally fatigued, if I can put it that way. Okay, I'm from Kiambu County, but working in Nairobi. Then another thing, this one goes to the Ministry of Health. Are we still handling the COVID patients or post-COVID patients according to the guidelines that you laid for us? Are we still packaging them in 2 body bags? Is there still no embalming? Is there still no viewing of the bodies? Because it tends that we forgot the guidelines that were laid down for us. Then last and not least, this one goes to the Dr. Kimani. For example, if a mortician gets injured at the place of work, you and your fraternity, what do you tend to do? Because morticians we are health workers, and we tend to be forgotten. Countrywide, national-wide, in the county levels, we tend to be forgotten.
So you said you're members of the KPNU? Okay. The gentleman over there, just kindly give us your name.
Thank you. My name is Mohamed Duba.
Mohamed Duba.
Yeah.
Thank you.
Chair, Kenya Health Professional Society, and Secretary General Association of Public Health Officers, Kenya. My question is just on OSHA. It's very brief. Is there a time limit within which you are supposed to claim? Because we are made to understand that the compensation is within a given time limit. Yeah, thank you.
Thank you. Is there a time limit? Could you hold the questions right now so that at least he can answer them? Then we'll take just the last round. I take 2 questions, then we're done. 3. There are so many of them. Dr. Kimani, Dr. Simon as well, you can answer those questions.
Okay, thank you very much, Dibal, and thank you for those questions. Let me start with my colleague from Migori County. The compensation is paid by the National Treasury, and I'll be honest here, we have been requesting the National Treasury to give us a report of the payments they have made. But unfortunately, they have never given us a report, in spite or despite of our repeated requests, because we also need to close the files. Because as I told you, we are involved in the administrative processing. So we need to have closure that this person was compensated or their family was compensated. So unfortunately, I cannot answer your question because we don't get official feedback from the National Treasury.
But that does not really stop the fact that it's their right to actually get this compensation. So if you don't get feedback, then what does he do?
In fact, it's been a parliamentary question. If you follow the Hansard, I think it's constantly asked in Parliament by members of Parliament. And the National Treasury always tells them they'll give them a feedback, they've set aside this money, but we never get a report. So those files actually remain open. There are currently around 7,000 files that we've processed, which remain open. Now, for my colleague from Kisii County, at the Directorate, we only enforce the Occupational Safety and Health Act, and we administer the WIBA Act. When you talk about dismissal, that might bring in the other labor laws, the labor relations and all that. So for you to dismiss a worker, there is a laid down procedure, but unfortunately I'm not a labor officer. There is a laid down procedure of how you can lay someone off or dismiss them. And if that procedure is not followed, there are grounds to take the matter to the labor department so that they can go through the process. And if you're still dissatisfied as a worker, you can take the matter to the Labor and Industrial Relations Court for you to get a judicial pronouncement on the same. So on matters of dismissal at the directorate, we don't handle that. For us, we just handle occupational diseases, and COVID-19 is one of them, or occupational accidents that lead to some permanent loss of function or permanent loss of a body part. Now, for my colleague from the Kenya Professional Nurses Association, the treasurer, what are the requirements for you to claim for COVID-19 compensation? There are quite a number of them. One is you need to report the suspected COVID-19 workplace infection. And reporting is by using certain standardized forms, which I shared with you. They are in those two documents, the OSH policy guidelines for the health sector in Kenya and the National Infection Prevention and Control Guidelines. So on Appendix 1 of the OSH policy guidelines for the health sector in Kenya, there is a form we call DOSH 1. This form should be filled within 7 days of the occurrence of this suspected occupational disease. And then we also have Appendix 9 in the National Infection Prevention and Control Guidelines. But even if you report late, it still does not negate the claim. Because actually most of the times people report later. We've had even of people reporting a year later. But legally it should be within 7 days. Then after you have made this report, of course there needs to be evidence that you tested COVID-19 positive, so we need the PCR report. And with these documents, then we wait for you to complete treatment. Deputy SG here mentioned that he is a COVID survivor, and congratulations, and thank you, Lord, that your time is not yet over on this earth. So once you complete the treatment, and the treatment can vary, but generally, if you get COVID-19, within a year, you're likely to have received your treatment and recovered adequately. So there is a timeline. Somebody had asked, is there a time limit? The time limit is normally 1 year. So if you suspect you have COVID-19 or you confirmed and you think you got it from the workplace, within 1 year, we should have finished the administrative processes for your claim. However, and Dibal, I'm very impressed with your knowledge. He's mentioned long COVID. Long COVID, I think we have seen some people, even beyond a year, they are still having the complaints. So for certain diseases which have a long duration of time, the 1 year time limit may not apply. But for the others that the time limit of 1 year applies, there is that time limit. But if it's now coming out that it can even be longer and you develop one of those long COVID, we will have to wait until you recover so that we'll be able to complete your administrative processing for your claim, awaiting Treasury to pay you. Sorry. Then we had a question from our colleague in Kakamega County. She mentioned healthcare workers getting tuberculosis in the workplace. Now, of course, we know there is pulmonary tuberculosis and extrapulmonary. But once you complete the treatment, if you have full resolution, and let's use pulmonary TB because it's more common. If you take your anti-TB medication and then you recover fully such that you don't have any respiratory deficiencies, and these respiratory deficiencies are as assessed by a chest x-ray, CT scan of the chest, and lung function tests. Remember, all of us, for our weight and height, we have a certain lung volume that is expected. So once we assess all that and you have recovered fully, then you don't qualify for compensation. Remember, I said as things are currently, you're only compensated for permanent loss of function or permanent loss of a body part. But for those who get TB in the workplace and they have completed the treatment and they are assessed and they have, let's say, 80% of the expected total lung volume, that means they have a 20% loss. So they will receive compensation for that 20% loss, specifically for TB. And just on TB, I think we have been invited. The Ministry of Health is working on a national TB in the workplace policy. So those matters will even be brought even closer because it was felt that we need such a document to make it easier for healthcare workers to know how to handle TB in the workplace. And then for our colleague Catherine, for the morticians, the Occupational Safety and Health Act covers all workers. All workers. Even our chief executive of the Republic of Kenya is a worker. If he gets injured, OSHA will apply and all that. So it's not that you're not covered. Maybe there is no awareness among the mortician fraternity to report these cases. And just like I said, it's not just among the mortician fraternity. Generally, healthcare workers are not aware of the requirements of the Occupational Safety and Health Act and WIBA, but we are trying to improve awareness by going to the ground and training them so that they are able to be aware. So you're covered. Anytime any of your fraternity are injured in the workplace, it should be reported. And once they complete the treatment, if there is permanent loss of function or body part, they qualify to receive the compensation, just like any other worker. The only exemptions to the OSHA Act are people in our disciplined forces, the defense services. Them, they operate under the defense laws. Those are the only exemptions. Then for Mohammed, I think I mentioned the time limit is normally 1 year for the conditions that should resolve within 1 year. But if it's something that extends, then the period of time is extended until you recover to the fullest extent possible.
Thank you.
Thank you.
Right.
Thank you, Catherine. I think you posed a question about whether we have stopped observing protective measures in a high-risk area in the mocks, for example. I think the mock qualifies to be high-risk area, and precautions still should be observed there. Yes. So I think public health measures for within restricted areas, offices, and workplaces still holds. So I've not seen guidelines to the contrary. So thank you for the feedback, though, because that is very important that we need to re-emphasize until at that time that the necessary measures, the guidelines will lift certain restrictions. But I think I also want to remind you that to be on the alert, because the ministry is also developing the patient and healthcare worker safety policy and guidelines. And I was thinking wildly, your clients also, the safety of, is it yourself, and you need to have an input there, because what we need to call because we have to also exercise safety within the mock, isn't it? Yeah, so you need your input there. Thank you.
And of course, we appreciate the morticians and the work that you do. You're never celebrated, and I think we can take a handy opportunity and appreciate the morticians here in this country. Even when they were going through these story times, handling the bodies as well, it was a trauma for them, so we really do appreciate you. We have to leave it at that. I know there were more questions, but I think we'll give you a handy opportunity in the next session if you have these questions. And if most of the panelists will be lingering, we pray that they do at the end of the day, so that we can continue with the conversation then. So I want to thank you so much for, first of all, our panelists for electing to graciously electing to be part of this conversation and illuminating, of course, some of these issues that are very poignant at this point in the country. So I want to thank you warmly. You can give him a round of applause again. Thank you for the good work they've done. And to you, lastly, thank you so very much. I want just to hand over back the meeting to the MC to guide us on the bites, the lunch that and then also for the next session as well. Thank you. A round of applause for us again. Thank you so much.
Thank you very much, Bar, and the panelists for that vast knowledge that you have shared. We appreciate. And of course, there are very many questions which have not been addressed, including, I know, we normally have questions like our colleague who disappeared in Mandera by virtue of what happened there, where does their fate lies. And today, of course, one of us was saying, is it a white elephant, when we say there's someone who raised the claim but never know when it was paid. So I think there is an open, there is a question mark there. I think as the healthcare workers, we are here to discuss the issues. We will follow up on that.
But I wanted to note as well, I think, Victor, that is a good point for you to, put your activism to bear. Right? You can come to the media and you say you need compensation. You've had Daktari is here as well. So there's a time that you can collectively, Teresa, Deputy Secretary, now compensation, you give now this, and I think Dr. Kimani will give you the statistics at the end of the day, so that at least you have data to actually also steamroll. So you can put we are ready as media to support you. Just say, Dibal, we will come with the cameras. We need to be compensated, and Daktari is here is attesting to that fact that you need to be compensated at the end of the day. Thank you.
Very true, and thank you very much, because why I said that, there was very clear that there is some opaqueness in and lack of transparency in handling that issue. And I think, Dibar, thank you for opening that issue, and we want to say, we can also recruit you, you'll be on our side. You can be our members in the union, and yes. So having said that, I want to welcome you for lunch. As the panelists will be leaving here, they will be leaving directly there. We are behind schedule. And when we are coming back, we want to take at least 15 to 20 minutes. I'm looking at that schedule, and I'm looking at the very component issue that we, thematic area that we need to capture, especially on financing, where all of us are saying we have issues. Because if we need to employ more, we need more money. If we need our hospital equipped, we need more money. If we need more infrastructure, we need more money. If we need good training for our professional, we need, so that is the issue we need to focus on in the evening. And still we'll be having the bar here in the other panelists, I think so. And we want to welcome you in the evening. As we're going for at least our lunch break, I want to ask, fortunately Tricia is still here, someone to pray for our lunch. Just Ramba. The center Ramba. I can share this. Then once she's done, all of us will go down, serve, and take the shortest time. Let us be our own timekeeper.
Thank you. Let's bow our heads and pray. Oh Lord, we thank you for this opportunity. Thank you for whatever we are deliberating. We pray that you continue being with us as we started. Now as we head for lunch, we pray that you be our guide, and the food that you are going to take, we will bless it and bless us. In Jesus' name we pray.
Thank you.